Well, I'm very glad to join after that excellent cardiovascular talk. So I don't know if everybody caught some of that, but that was really, just wonderful to hear because sometimes that also ties in with contraception. So I get to talk about contraception today. And then I'm going to figure out a very simple, there we go. This is actually the graphic I'm going to keep up the entire time because I think it's really quite helpful when I think about when I first was kind of introduced way back as like a student, right? College student. You sit there in the exam room area and you see this like at student health, this like poster up on every wall and door. And, over time, it's not like that much has changed, except they've kind of come up now over the years with a little bit kind of better information, just finally as more and more studies, thank you, are being performed to kind of get an idea about length, duration of contraceptives out there, and just kind of further refining some of the stuff that exists. There continues to be some other options maybe being kind of explored even down in the like realm of male contraception at some point, but that still always is kind of a who knows when situation right now. But this graphic has really certainly stuck with me just in general, and this is just from our OBGYN organization from ACOG. But I like to kind of point out some things in general and just really emphasize, if you take away really anything, is that contraception really can become a very personalized, individualized care kind of thing. Just understanding heart disease risk, even when we talk through that, blood clotting risk, medical risk. We talk through, especially one of the newest things is those GLP-1 agonists that a lot of people are on, and they may not intend to have a pregnancy, or maybe they're trying to get healthy in order to be pregnant and get pregnant at a time they didn't expect. A lot of times we're learning about what medications that more and more develop through time, how does that impact both fertility and failure risk of contraception and also early pregnancy. So important pieces for when people are trying to optimize their health risk, kind of really all part of what's considered family planning, just kind of getting a better idea and time frame when we're trying to lower the risk of the heart disease that our previous physician, Dr. Millate, mentioned also. Okay. And so kind of we go through some options for the more, like what's considered more effective. That's kind of the simple graph up there, and what's considered less. Now, if we kind of point out, let's see, let me figure out this pointer right here, this kind of fertility-based method, the most updated piece of that really is now people are starting also to explore apps. And actually there is a one FDA-approved app called Natural Cycles, I think, that is kind of been shown to reduce pregnancy when people are truly like sticking to it, which nowadays everybody has their phone, right? So it's kind of a simple, straightforward way maybe to enlist in that. Now, there are, of course, you wonder about healthcare privacy and all these kinds of things. And so that's where some people may not prefer that. Or back when we all started our cycles and had like a calendar, literally just kind of marking it down, right? And so it's very much the same thing like that. It also is quite helpful for when people are eventually like trying to time and figure out like for trying to conceive if they have the opportunity to plan. But obviously I think it's something, anywhere 50 to 80% of pregnancies are something like unplanned, right? So we kind of go through, when they occur, what makes the most sense maybe if, we're trying to time a little bit more optimally. And then this kind of points out like diaphragm. So, through the years, you always learn, even as an OBGYN, okay, I'm going to learn how to fit people for a diaphragm. You do all the work and then nobody can actually get it from a pharmacy hardly these days anymore. So they're like, I remember trying to prescribe it and getting actually the best information I found is now there are some healthcare companies really trying to directly market some different devices and things like that for people who are committed to more non-hormonal contraception. And, the thing with the diaphragm, or there's like cervical cap, all these kind of that exist down here, or anything that would involve spermicide, they're just generally harder to tolerate for a lot of women because of the vaginal symptoms that can come along with trying to use those methods. And so, there is, I wonder if they put it on here, there is something newer. Now I'm going to forget the name for a minute. It'll come to me while we talk. But that's kind of an insert that can be used before sex as well. And that is something that can be available. But again, these, at least that one is supposed to be a little bit more pH balanced. And so we have to kind of watch for what causes vaginal discharge, infections, risk, itching, burning, and pain, and things like that. But some people can tolerate those. And so, there is a company that I think Kaya is the name that will directly market like a pretty much one-size-fits-all diaphragm that I believe still currently needs a prescription. Okay. And then many of these are also over the counter. So that's kind of an advantage for a lot of people, right? So even sometimes 24/7 from wherever it needs to be picked up from the store or something like that. Now then we kind of move up to like the prescription methods, which tend to be more effective, but involve hormones. And that is where, health risk assessment comes in. Over the years, there's been lots of discussion within, kind of our national organization about offering contraception as over the counter, which has been really well supported when we kind of look at what is available and lower risk for people. And actually now there is one. And so there's something called O-pill that does not require a prescription. And it is a hormonal contraception method, but it has one hormone. It's progesterone only. So it really becomes pretty widely available for basically most everybody. And it is just as effective over the counter, but then priced sometimes, when we look at now, like with the Affordable Care Act and coverage of contraception being wrapped up into that from over the years, the nice thing is actually pills can become free. But if some people don't have insurance or maybe can't be able to go to see the clinic or something like that, and they like the opportunity to pick up over the counter, that is a nice available option. And I believe that's the only over the counter right now. And of course, companies like to hold on to patents to make that money, but there will be hopefully some more generics and things like that down the road, maybe even cheaper. I think it was last I looked, it was like $25 to $35, something like that for a month. And then if we look at kind of the other methods up here, so a patch, I do certainly have a lot of patients who like the idea of a patch because it's once a week, it goes onto the skin. The kind of harder timing is if you try to go ahead and have a menstrual cycle. So some people talk about contraception as, birth control only, but oftentimes we're also using it for cycle control, and that has its benefits. We even see it beneficial around like perimenopause as we're talking through bleeding changes, maybe an early onset of cycles when women are just starting to have periods and their bodies still are not quite adjusting to a typical kind of calendar that helps them bleed a little bit less. So that's where there's some benefits, and also, of course, for acne and different kind of cycle or mood symptoms. And so there's definitely some options out there. And so patch, sometimes I find a lot of times it's our younger patients maybe who tend to choose it, which is fine, but anybody can use it as long as we're looking at estrogen risk as being tolerable for people. And there are a couple different patches out there. And then, of course, for it to stick, that's important. And then knowing, too, that it doesn't come off swimming or, hot tub, all that kind of stuff, and making sure it's still on for it to be effective. But if used effectively, it really does fall into quite like that high risk, high effective category. And then vaginal ring. So that one, that's actually has a little bit more advantage too for some people, being once a month use, or there's even now this newest, nobody can buy it yet because it's always expensive, but you look for the manufacturer coupons, once a year ring, which is great as long as you don't lose it, obviously. But I laugh about like one of my friends who jokingly calls her baby Nuva ring, because that's a vaginal ring that was, you just have to make, so some people will take it out for intercourse or leave it in for sex, but then it's just a matter of making sure it has remained in there. There's like basically within a 3-hour window of the ring being out that the hormones can change. And that's, when we look at how these work, they're kind of helping kind of prevent that ovulation. And that's when we start to see the hormones start to stimulate things back again. Not that at 3 hours it will do that. That's pretty quick. Usually for many people, it may take more in that 24 to 48 hour window. As opposed to some of the stuff up later in the slide, which almost may take a year for people to come back sometimes to their cycles. But just like we've all heard maybe that if somebody misses a pill, they can very quickly have risk for pregnancy. It can be that way for some people, and that's where some pills that are progesterone only are pretty kind of critical timing-wise to take within roughly about the 3-hour kind of time every day. So, alarms on the phone, different kinds of things people set, or routine. And then the depot shot, this is kind of really primarily the one injection that is currently available. Sometimes it's available in a skin injection, sometimes in the muscular injection form. The subcutaneous one, some people have had actually a side effect of where it's injected, the skin itself kind of has a little bit of fat change, so little divots in the skin. So I've seen that. So it tends to be favored to be used in the muscular injection form, but some people don't just learn how to do it at home, so that's convenient. It's still worldwide pretty popular because of the effective nature of it, and then kind of the adherence. People are able to keep up and take it. And it is nice for patients who run some higher risk. Like many people have been learned in their lives that maybe they're not a great candidate for estrogen because of migraines with aura. And when we're talking about that kind of estrogen, a little different than the menopausal estrogen, we're talking more about the contraceptive estrogen, which is synthetic and it runs a little bit of that risk for aura and stroke risk. Is kind of why we talk through that. So the depot shot's actually favored and a good option, but some of those side effects, weight gain, as much as like you try to read and tell people it most likely does not, clinically, absolutely, I see that one does favor a little bit more weight gain, appetite stimulation. Just kind of, it's a really potent progesterone, and it works really well. Like some people have used it for years and years, and you're supposed to kind of actually give a little window of a break to allow the bone health to also return, because it is so strong. It almost kind of surpasses even some of the natural estrogen effect your body tries to maintain while using it. But it is very effective, and it often is a very good choice sometimes for teenagers or people who do have high risk and need contraception, maybe because they do have heart disease or stroke risk and are not trying to be pregnant while they're optimizing their health, or not trying to be pregnant at all. And then there is, or even like perimenopause, many people, fibroids, different reasons will use that too. So sterilization, then we go up to like the most like permanent. This one shows a permanent sterilization method that we, used to do most often. Nowadays, we're starting to do a little bit more actually of just removing the tube entirely, which is the most effective and may actually have some benefits to even helping prevent ovarian cancer, which is a really great side effect. Actually, you don't get many good side effects of medicine, but that's a very good benefit. And that helps actually. They've been studying that now for people who have hereditary cancer risk, like BRCA genes positive and things like that. For maybe people who are too young yet to lose their hormones naturally and run the risk of using other hormones for menopause treatment, to maybe remove tubes alone, but also truly for contraception, and it's very effective. But for women, it's a little bit more of an invasive procedure, but it does still, carry, I'd say, less risk than what kind of has been brought onto the market and left. If you guys have ever watched, there's something like On the Bleeding Edge, I think was this little Netflix special about the Assure coils, and honestly, things over the years that I have used in training, and you go back and think, well, you know what, I'm glad we have learned better that maybe there are a lot of risks with these things. And so kind of in a way, it's yes, we're taking something out. We watch for the risk potentially on hormones, which should be more temporary. And that's usually what I see for some people. It's not as associated with earlier menopause, like something like having a true hysterectomy or removing the uterus, which of course is not listed because we don't really use that for just birth control. It has its own risk. And then, which I still continue to have people who ask me about it, and we just talk through, why we don't just kind of do hysterectomies like as easily maybe as once was thought. IUD, that's of course still one of the best contraceptive options out there. Some people like the copper one versus a hormone one for various reasons, and it's important we kind of talk through what it means to keep selecting one. But actually, one of the better things too now is out there in discussion too about like pain control for insertion, how it can be used easily and things like that, where it, a lot of people used to be quite afraid of using it. At least now we're talking through how we can better manage pain in the office and clinical exam rooms. And, while I may offer it, many of my friends may offer like some kind of additional pain control other than saying, okay, take a deep breath or cough kind of thing. And here comes the IUD. But it thankfully has become now actually even recommended within professional organizations to address the pain control. If we imagine, honestly, when we think through people who get vasectomy, they get option for even anesthesia or kind of other procedure pain control. It's absolutely important to know that, placing IUD, that cervix does feel pain, and it's maybe different pain, but it's not necessarily pain-free. And so for sure, and everybody has variation. I won't want to scare people because I think an IUD can be tolerated very well. Sometimes we offer medication in advance to help relieve the pain, and then kind of go through selecting which makes the most sense for a patient to try to either control cycles, or maybe people who don't tolerate hormones, people who prefer copper IUD. Technically, I'd say the hormone one is just like we're talking points of percentages more effective with the hormone because it's not so critical exactly the location of the IUD, as in it should be in the uterus. Risk of an IUD is important to address. Some people, no matter what they try, I have some people who really, really want an IUD. They try it. It actually starts to lower and fall out, basically. And so obviously nobody wants that. That's not effective when it's not in the body. But it can be something, if somebody's attached to trying it again, we go ahead and try it in the context of maybe we wait longer from when a baby was delivered, or give it some more time, or figure out, was it properly placed in the first place, different kinds of things. And they're different sizes. They actually now over the years have kind of made smaller ones that last pretty much just as long and things like that. May or may not have as much hormone then to help control the cycle symptoms, but it's a nice option and also has its role now more and more. We're kind of learning how it works well for protection during menopause, while people are even seeking hormone replacement type therapy, or also to help the bleeding changes, prevent uterine cancer. Lots of good benefits medically, but also still temporary if wanted. So if people get it, remove it for pregnancy. That one works faster to be out of the system. The depot shot, that one can actually last in the system for 6 months to a year before ovulation and cycles come back. And then finally, that implant up there, if anybody's heard about the Nexplanon, that kind of sits in the arm right underneath right here. And it is kind of nice for a lot of patients who are like, okay, I want one of the most effective forms that's reversible and also is not like as invasive feeling as a pelvic exam type procedure. And of course, honestly, all of these things can be offered and discussed without already doing a pelvic exam to begin with. But obviously, we're just generally often assessing a patient's other risks. Do they need a pap smear and things like that? But, I don't want people to be afraid. Initially, a lot of times the general culture in OBGYNs will make sure they have a pap before we do any birth control. Not necessarily, so we can talk through who needs a pap smear, when to do it, and things like that. But the implant is kind of nice for patients, especially young ones maybe, or people who've really liked their implant or who have other risks. Because not everybody can have an IUD either just by their own anatomy. There's some other reasons that they can't actually keep an IUD in. And so the implant doesn't tend to travel or fall out or potentially can go through the uterus or have some other risks. Some people fear the IUD because of the risk for needing a surgery, or is there permanent complications down the line. It should not affect the ability to still have babies and things like that. Sometimes there might be a little bit more a procedure involved to remove it if it has traveled, when obviously that's not the optimal goal. But we're talking less than 4% chance of these complications of IUD location, which is pretty good. But and then the implant, they kind of over the years really still only have the one that we use now. There used to be something called Norplant, and I don't know if anybody's familiar with that one. That one is a little bit more complicated for removal. This one's pretty straightforward, kind of like removing a splinter. So that's what I tell people. It's a little bit more straightforward. But I don't know, I get to talk about a very pretty straightforward topic, but figured I'd also leave the floor open for any Q&A, and if not, that's okay too. Just know I'm over here in the 12th floor. I work alongside actually Patty. I think he'll be speaking later, and I think a couple of my colleagues have been talking around here today. So.